Thank you so much for the invitation.
Now we are running late, so without saying anything more, I request Dr. Narasimhan his deliberation on multiple ventricular ectopies on halter. That you have to investigate, treat, or ignore. 15 minutes for this deliberation. Narasimhan, please.
Thank you very much for the kind invitation. Over the next 15 minutes, I'll go through the approach to frequent PVCs on Holter. Now, the context in which the PVCs came to a clinician is important. If you're investigating a patient, serious symptom like presyncope or aborted sudden cardiac death, even if the PVCs are infrequent, they have to be. And when you're investigating a person with palpitation, occasional skip beats, you need to risk stratify whether it's benign to be ignored or given just a beta blocker. Whatever be the cause of PVC, over a period of time, if there are dense PVCs, frequent PVCs on the Holter, their overall survival is less in terms of increased mortality due to heart failure and sudden cardiac death over long-term follow-up. Now, as a clinician or a cardiologist, we are worried about this catastrophic complication. A benign PVC, what was ignored, shouldn't trigger a fatal VT and VF when resulting in. Now, are there any indicators? This is several years ago from Cleveland Clinic, which looked at over 30,000 patients who undergone exercise stress testing and showed that when you have PVCs during exercise and during recovery, both, they have an adverse prognosis over long-term follow-up. This is an 8-year follow-up study. There's almost 20% death in those subset of patients. Now, when you have this, the resting heart rate is very important. When you have PVC in a Holter and the patient's resting heart rate is, say, 55 or 60, they have an adverse prognosis and you need to take it seriously. Now, whether there is an underlying structural heart disease and the PVC is a marker of the structural heart disease is an important question. And therefore, you need to ask family history to exclude channelopathies, ECG and echo to rule out structural heart disease, TMT to rule out CPVT and long QT, and in suspected cases, MR be warranted. About 3 decades ago, we used to think PVCs were benign till such time this French group showed that a short interval in PVC indicates adverse prognosis. They can lead on to VT and VF. A coupling interval of less than 300 milliseconds generally indicates a more malignant form of PVC. On the other hand, when you have a late coupled PVC, it very often leads on to this kind of post and they're developing, it's a reversible cause of LV dysfunction. Now, let's look at the Holter tracing. This is a patient with a PVC, a long coupling interval. What I want you to concentrate is on the STT changes before and after the PVC. If there are no STT changes, this means the electrical milieu is a little more stable. On the other hand, if you take this patient, you look at the QT before the PVC, rock steady, 380, 380, 380. Following the PVC, there is a prolongation of the QT interval. Not only does the QT interval prolong, the T wave becomes abnormal. This indicates very often you need to investigate this patient for a possible structural heart disease. It may be cardiomyopathy or a genetic channelopathy. But when you look at it in the Holter, this single point is enough to tell you that you need to investigate this patient further. Let's look at another example. PVC, STT normal, PVC that happens at the end of the T wave, but look at the T wave amplitude that happens after this. A remarkable increase in T wave amplitude following a pause indicates that this is not a benign PVC. You need to take this patient for further evaluation with a proper echo, strain imaging, or even an MRI. Similarly, when you look at patients where the STT was relatively normal before PVC, post PVC, T wave may get inverted. In the olden days, this used to be called as poor man's exercise test, where following a PVC and a long diastole, you can get subendocardial ischemia and you can get STT changes. Similarly, where you have a T wave that is inverted before, after a PVC, there is a pseudo-normalization of the T wave. This is abnormal. This again indicates that this patient needs further evaluation for structural heart disease. You can't pass this as a benign PVC and send the patient back home. Again, another example, PQRS, a late coupled PVC, a long pause. Following the PVC, a very prominent U wave. Suddenly, a prominent U wave happening after a PVC again indicates there is a significant repolarization abnormality, and this patient needs to be evaluated further. In the recent past, we have also understood that varying coupling interval of the PVC indicates high-risk PVCs in terms of either risk of VT and VF, underlying structural heart disease, or progression to heart failure. This is a case example. I've shown this before of a lady with frequent PVC came for evaluation with varying coupling interval, degenerates into VTVF, ultimately within minutes going on to straight line. Now, do we have any evidence to say that this is high risk? These are patients post-MI PVC with constant coupling interval. Whereas when you have certain fatal mutations like lamin AC mutation and phospholamban mutation, the coupling interval is highly scattered in a given individual. So whenever you see varying coupling interval in a person what looks like non-ischemic cardiomyopathy, please evaluate them for lamin AC with either an MRI and genetic testing. Because even when the EF is relatively preserved, the risk of sudden cardiac death is higher among these patients. We have also learned that when there is a very high frequent PVC burden, there is a reversible cardiomyopathy due to PVC. Abolishing the PVC either pharmacologically or by catheter ablation reverses the LV dysfunction in several of these patients. What is more important is this study which came from University of Minnesota, which looks at the diastolic function. This is the reason why patients with PVC, even though they don't have much of structural heart disease, they have significant dyspnea. And after ablating the PVC, you find there's favorable LV remodeling and the diastolic indices improve significantly. Holter, please pull out the patient's 12-lead ECG and to see whether the PVCs are varying in morphology and the company that it keeps. If the PVC is associated with fractionated QRS on resting ECG, you need to evaluate this patient for possible genetic cardiomyopathy or inflammatory cardiomyopathy. Among patients with post-myocardial infarction, LV dysfunction, whenever you have PVCs on the Holter, resting tachycardia, QRS duration that is prolonged, fractionation of the QRS, and the ST segment shifts on the ECG, and a QT interval that is prolonged on a resting ECG indicates that these PVCs in post-MI are a harbinger of sudden cardiac death. And you need to have a lower threshold to give us ICD for these patients. So as a clinician, when you have a Holter showing frequent PVCs, you go back and ask for symptoms. If there are malignant symptoms like patients having syncope, you need to investigate them immediately, irrespective of the EFs. On the other hand, if the patients have just palpitations it's imperative to take care of the 12 lead ECG to look for any evidence of QRS fractionation or a pathological Q wave, echo to look for structural heart disease, and MRI in occasional cases. If there is structural heart disease, you need to evaluate them and risk stratify accordingly. But whenever there is no structural heart disease, there are electrical markers of sudden death or electrical markers of malignant PVC. They are short coupling PVCs. Coupling interval is short, varying coupling interval PVCs, PVC that persists during peak exercise and persists during recovery, and varying or pleomorphic PVC on Holter. These things indicate that they are high risk or malignant PVCs. You need to evaluate with an MRI, and in case there is a scar, have a lower threshold for giving an ICD for these patients. The company it keeps is important. Whenever the Holter shows PVC, look at the 12 lead ECG for evidence of QRS fractionation or fascicular block in these. When you have fascicular block or bundle branch block, QRS fragmentation or very low amplitude of QRS, these things indicate there is myocardial edema or fibrosis. You need to investigate these patients further and not pass them off as benign PVC. Among patients without structural heart disease, the approach is predominantly to treat them with beta blockers or calcium antagonists. Whereas among patients with structural heart disease, the initial drug of choice is sotalol. For elderly persons, it may be amiodarone or a combination of sotalol and mexaltine or amiodarone and mexaltine to suppress the PVC. When the drugs fail, you have very effective catheter ablation therapy, both for idiopathic PVC and structural heart disease PVCs. When drugs fail, we tend to offer them a very early RF ablation as a curative form of therapy. So again, to reiterate, the high-risk indicators of PVC in the Holter are during daytime exercise-induced, when the patient has an underlying LV dysfunction, pleomorphic or multiple morphology PVC, short coupling intervals, varying coupling interval PVC, and when there is family history of sudden death, these are high-risk indicators. In all these patients, as a clinician, it's important to exclude underlying structural heart disease. If they are benign PVCs, you can treat them with beta blocker or calcium channel blockers. And frequent PVC or non-sustained VT in the presence of LV dysfunction or hypertrophic cardiomyopathy, you need to risk stratify them with MRI for giving them an ICD if required. When PVCs continue to be symptomatic, unresponsive to medical therapy, or it's triggering an LV dysfunction, you should have a low threshold for considering catheter ablation for these patients. Thank you very much for the patient listening.